Good afternoon, everybody. Thank you for being here with us. And thank you for the committee for giving me this uh, duty today. And here I would like to present to us all about the combination therapy in painful diabetic neuropathy. I think we all can admit that this is one of the most difficult clinical problem that might usually come to our practice. And here we will talk a little bit of focusing on the combination therapy. So to begin with, I would like to remind us all that this particular spectrum of diabetic neuropathy, painful diabetic neuropathy, considered to be occurred in about 25% to a third of patients diagnosed with diabetic neuropathy. And painful diabetic neuropathy is well known as a serious problem that could impact the quality of life, including sleep, anxiety, and depression for patients with for the patient. And for now, with all of the medication that we have, we can only promise the patient that they might. Our goal is to at least to reduce the pain for about 30 to 50%. So that's our position right now. So let us review again about the medication that is now becoming options according to the recent guidelines. You can see here that most of the guideline here, American Academy of Clinical Endocrinology, American Academy of Neurology, and so forth, recommends the use of tricyclic antidepressant and SNRI, as well as gabapentinoid as the first line choice of the medication for painful diabetic neuropathy. With the addition for the American Academy of Neurology, the recent guideline, they also recommend the use of sodium channel blockers like carbamazepine, oxcarbazepine, lamotrigine, and lacosamide as the first line option for painful diabetic neuropathy. What seems to be quite interesting here is that several guidelines still recommend the use of opioids, but we need to be very careful about this. I will come to this later. So these are the options that for now is recommended according to several guidelines. And now for clinical practice, we know that when dealing with painful diabetic neuropathy, it is not enough only for treating the pain problem. We still have to be focusing on the risk factor and lifestyle modification, and to obtain the optimal glycemic control of our patient, as well as cardiovascular risk factor control, and also to combine all of these approach to non-pharmacological modality, because it might be able to increase the pain relief that we might achieve. So for monotherapy, as the one that I have talked previously, we may choose the gabapentinoid agents like pregabalin or gabapentin, or antidepressant. We can choose tricyclic antidepressant or SNRI. And if it is only giving a partially effective, we might consider to add the second treatment and give the combination treatment to the patient. Or we might also try to switch the medication with another type of medication. So that's the choice. And for now, I will be focusing on combination pharmacotherapy by showing us some evidence that might become the basis for us to practice this in our daily practice. So let us begin with this study here done by Tannenberg et al. and it was published in Mayo Clinic Proceeding in 2011. So in this study, it is an open label study, consists of 407 subjects. They evaluate all the patients who are non-responders of gabapentin. So for those patients who are non-responders, meaning that the daily pain score cannot reach less than 4, so they assign the patient to 3 groups, the duloxetine group, so they switch the gabapentin to duloxetine. The second group is they switch the gabapentin to pregabalin, or they add duloxetine to pregabalin. So this is a 12 weeks open label study, and we can see here that in this graphic, the combination group, which is gabapentin plus duloxetine and duloxetine, seems to be giving more pain relief compared with pregabalin. So what this study suggests is that we might consider to combine the first line medication for those who are not responding for previous medication. So this study, can become one basis for us for our daily practice. It also says here that in this study says here that don't forget about the side effect, of course. But actually, the side effect usually is easily occur when we increase the dose. But when we do the combination, it usually that the component, each component require lesser dose than if we do single treatment. So the side effect is not that significant compared with the high dose monotherapy, and this study suggested. The second study is combo study. Combo study was performed by Professor Tesfaye, and it's okay, no problem. Tesfaye, and it was published in Pain on 2013. So what they do in this study is that for those patients treated with single medication, either pregabalin or duloxetine, they evaluate the patient for about 8 weeks and then decide whether they are responders or not. Responders mean that the pain reduction reach to the score 3 at the most. For those more than 3, they consider them as non-responder. And after that, all of the non-responders divided into 4 groups, either to get increased dose of duloxetine up to 120 milligram as needed. If the patient need increase, they would increase the dose. And the second group is duloxetine plus pregabalin. The third group is pregabalin plus duloxetine, so in combination. So if the first group is duloxetine group plus pregabalin, the third group is pregabalin group plus duloxetine, and the fourth group is increased dose of pregabalin. So in this study, it is concluded that it seems that combination group provide a similar pain reduction compared with the monotherapy with high dose group. So this study also support the concept of combination treatment, although we need to seek for the probability of side effect. And the recent study that I think this is quite popular until now, recent study also done by Professor Solomon Tesfaye from United Kingdom. It is just recently published in Lancet in 2022. So it is a specific study for combination medication, which started by dividing the patient into 3 groups: amitriptyline group, duloxetine group, and pregabalin group, and then evaluate them for about, you can see here, for 6 weeks. and then decided whether they are responders or not. Responders means that the pain relief or the pain score reach at the maximum of 3. So if the pain score after 6 weeks more than 3, it considered as non-responder. So for those group, for amitriptyline group, for non-responder, they add pregabalin, and for duloxetine group, they add pregabalin as well, and for pregabalin group, they add amitriptyline. In this graphic here, we can see that at 16 weeks after the study, the pain reduction score among 3 groups is quite similar. And we can see here also that among non-responders, the additional of the second type of medication could also give some pain reduction. So this study also support the concept of giving combination therapy for patients with painful diabetic neuropathy. And now let's talk about opioids. Well, we cannot forget that for now there are still some guidelines who suggest the use of opioids. And then what is the role of opioid? How effective are they in the term of combination treatment if we combine opioid with first-line treatment? So allow me to choose one study here, which is quite interesting. It is quite old. It is published in 2005. We can see here that additional of morphine to gabapentin is quite, we can consider it's quite effective to reach the pain reduction. But it's stated here in this study that usually the side effect regarding opioid usually is significantly higher than monotherapy, gabapentin group. And we need to be very careful for elderly patients, especially those with weight less than 60 kilograms. Another study is the combination between gabapentin and oxycodone, published in 2008. Similar result that the combination of gabapentin and oxycodone can also give additional pain relief compared with gabapentin alone. But again, be careful with the side effect because there are some specific side effects from opioid that we need to figure out. And then the other study published in 2009, it is a combination between pregabalin and oxycodone. We can see here that the additional of oxycodone to pregabalin in this study give the most pain relief compared with the other group. So it is considerable for us to select the patient to give opioid, but we need to be very careful. And according to this recent systematic review here, that after they gather all of the study regarding opioids in neuropathic pain, the safety and effectiveness is still cannot be extrapolated in daily clinical activities. They still suggest that if we want to prescribe opioid for our patient, it is better be in a short-term therapy and for highly selective patient. We need to evaluate the patient pre-prescription, with prescription, or post-prescription. We need to select the patient for and only prescribe for those with low risk of addiction. And also, try to give the lowest possible dose with the shortest possible duration, and evaluate the patient when they are on medication to avoid misuse. So this is the recommendation regarding opioid in neuropathic pain and especially in painful diabetic neuropathy. And then there are another set of treatment which is well known as pathogenetic treatment. We know that some medication is now getting popular like benfotiamine. It can reduce the age production, advanced glycation, end product glycation, and then believed to be reduced the nerve damage. And then there is a small study here stating that combination of benfotiamine and alpha lipoic acid, another pathogenetic treatment that is quite popular, could give some more beneficial effect in combination with standard treatment. Also, the combination of alpha lipoic acid and methylcobalamin could also give some beneficial effect, but we must put in mind that this medication here is considered to be the additional or adjunctive treatment. So to conclude the session, the combination therapy using first-line medication can be considered, and it is actually suggested according to the guideline. But we need to make sure that the combination treatment is only for those non-responders for single treatment. We need to be very careful and to evaluate seriously for the side effect and individual response. And then you can see from the studies the doses are quite high, which I think for us in Asia, this is kind of like a serious thing to consider, because me in my practice, my patient usually cannot handle this pattern of dose. So we usually prescribe lower dose. So I think we in Asian population, especially in ASEAN, ASNA probably can consider about making a study regarding this, because we cannot practice the dose according to Western world. So it is interesting. And then about opioid, we have to be very cautious about this. Opioids only be prescribed for selected patient, shortest duration and lowest possible dose. And the treatment goal remains the same. If we only use medication treatment, so the goal is only for 30 to 50% pain reduction. Patient needs to know this, because sometimes they wish that they have a complete pain relief by only taking medication, which is kind of impossible. And then do not forget that the treatment goal also to increase the quality of life of the patient. And then combination with non-pharmacological treatment, also from pathogenetic modifier drug can be considered, which also suggested that multimodal and multidisciplinary approach in this particular clinical problem is still recommended. Thank you.